Dear colleagues, dear friends, before the ERE Congress, which is very quickly approaching, we have for you a webinar on the very interesting topic with very interesting new data. And the main topic of today's webinar is anti-GBM nephritis. We have two excellent speakers, Professor Mårten Segelmark from Lund, Sweden, and Professor Adoo from Imperial College in London. And they will give presentations on two different aspects of anti-GBM disease. We will have one discussion at the end because the topics are similar, and you are kindly asked to give the lectures through the question and answers. And I will do my best to use most of them, or at best all of them, and have them discuss with our speakers at the end of the session. And of course, I believe that with most of you, we will also meet in Paris in a short interval of 3 weeks. And now I will ask my friend and colleague, Mårten Segelmark, to give the first presentation on the news in the treatment of anti-GBM disease.
I'm Mårten Segelmark from Lund University in Sweden, and I'm very happy to get invited here to talk about anti-GBM disease and a new treatment that I think in the future can prove very beneficial for patients with anti-GBM disease. First, I would like to acknowledge that I have received both consultancy fees and research funding from Hansa Biopharma, who have the rights for this new treatment. What I will cover today is a short background on anti-GBM disease. I will talk about previous trials and current treatment and prognosis in anti-GBM disease. And then after that, I will tell you about the results from the Good Ideas 1 trial. Anti-GBM disease is, according to the Chapel Hill Consensus Conference, defined as a small vessel vasculitis caused by anti-GBM antibodies binding to the renal or pulmonary vasculature. It usually starts with unspecific symptoms for a few weeks only, in some cases for a few months. And the most prominent feature is glomerulonephritis, and it's usually very rapidly progressive glomerulonephritis. In some cases, it is detected only more like an acute renal failure. A significant proportion of patients also have lung disease. It varies a lot between reports, but usually nowadays around between 20 and 30%. But there are with pulmonary hemorrhage. But on top of that, there are also some patients that have a subclinical lung engagement that you can only detect by X-ray or other techniques. The incidence is around 1.5 per million, and there is really no big difference between men and women. The pathogenesis is relatively straightforward. The IgG antibodies bind from the circulation to the GBM, where they start the classical pathway of complement, which results in the recruitment of neutrophils. The neutrophils get activated in the capillaries, and they undergo netosis or start to degranulate. And the enzyme released degrades the GBM, causing rifts in the GBM where blood can reach the Bowman space. There it coagulates with fibrin, which is a hallmark of crescent formation on immunofluorescence. And together with macrophage infiltrate, that leads to cell proliferation in the fibrin clot, which is seen as crescents. It is not clear if other mechanisms also participate. There are several animal models indicating that T cells can cause a similar damage, but it's not known if T cells have any important roles in human disease, except of course for promoting the autoantibody production. To my knowledge, there are only 2 prospective clinical trials aiming at the treatment of anti-GBM disease. The first one was conducted in the early 80s in the US, where there were 9 patients receiving standard of care at that time, which was just cyclophosphamide and prednisolone, and 8 patients received plasma exchange. Patients were treated relatively early in their disease, and renal survival in the control arm was seen in 33%. All of them having almost normal renal function to start with. In the PLEX group, there was 1 patient who had a creatinine clearance of 27 who exhibited renal survival at the end of the study. Patients with worse renal function ended up dialysis dependent. There was also 1 study in Sweden conducted by Segelmark et al., who looked where they tried to compare immune absorption with plasma exchange, and different varieties of replica RPGN was included in the study. Among the patients, there were 6 anti-GBM patients. 3 of them came in the PLEX arm and 3 in the immune absorption arm, and all 6 patients ended up dialysis dependent. So that is actually all what I know about prospective studies in anti-GBM disease. Well, based on this and much more, of course, on observational data, the current guidelines from the KDIGO that was updated last year with no major change from previous KDIGO guidelines say that patients should be treated with pulse doses of corticosteroids, with cyclophosphamide, and with plasma exchange, and of course with different types of supportive care, such as mechanical ventilation, dialysis, or whatever could be needed. With this type of therapy, results are not fantastic at all. Here I have listed studies from many places in the world, observational studies. And all in all, here are 784 patients. There was a recent publication just a few days ago from China with another 400 patients. I don't think that the figures will change very much, but I will update this slide as soon as I can. But overall, you can see that most patients in these observational studies have been treated with plasma exchange, and most of them have also received cyclophosphamide. There is about 20% who die during the first follow-up, and renal survival overall is 35%. But this is heavily dependent on how the renal function at time of diagnosis. If creatinine is less than 500 or 600, in different studies, but that would be usually above 10 milliliters in eGFR, then renal survival is actually quite good. It's as high as 72%. But if patients are dialysis dependent or have a eGFR then less than 10 in those, or it is 9% or so. So what could be done then in the future? Well, what I'm going to talk about is a substance called IDES, which stands for immunoglobulin G degrading enzyme of Streptococcus pyogenes. It's an endopeptidase that is highly selective for IgG. It actually does not cleave anything else but IgG. It leaves IgA, IgM, and so on unaffected. It's not, but it degrades all 4 subclasses of human IgG, IgG 1, 2, 3, 4, but not of all other species. Only some subclasses in mice and none in some in horse and so on. The high selectivity comes from that there is a double binding of IDES to the IgG molecule. First, there is a recognition in the Fc part, and then there is an actual cleavage of the peptidase that requires a specific amino acid sequence, and it cleaves only at one point at glycine number 237. It generates a FAB2 fragment and an FC fragment. This was discovered by Professor Lars Björk at Lund University around year 2000. And it has since then been developed into a drug by Hansa Biopharma in Lund. The non-proprietary name as a drug is imlifidase, and the brand name is Idefirix. And it's now licensed for the enabling transplantation in HLA humanized patients in Europe. And here you can see what happens to IgG in a healthy human person when they're giving a relatively small dose here, 0.12 milligrams per kilo of imlifidase. Within 15 minutes, IgG is transformed to single cleaved, that is that one of the FC fragment parts is cleaved off. And then after about here 2 to 4 hours, it's complete cleavage of all IgG into then the Fab and FC fragments. And as you can see to the right here, there is hardly any IgG to be detected in the circulation after 2 hours, and it remains so for a couple of days. But after about a week, IgG levels start to return towards normal levels. What would be the rationale then for treating anti-GBM disease with IDES instead of plasma exchange? Well, if we envision that when anti-GBM production starts, first it is at low levels and it's not really harmful for the kidneys. Low levels the kidneys could take. But when you reach a certain threshold, indicated here by a dotted line, renal injury will ensue. And then you detect the patient here at the next arrow and start therapy. And if you do plasma exchange, you remove most of the IgG in the circulation, but there is a significant rebound of the total body IgG. You remove maybe only about 30 or 35% by each session, meaning that you will need, with daily sessions, several days to reduce it 1 order of magnitude, and maybe you need to reduce it more than 1 order of magnitude in order to reach the line where we don't think the antibodies are toxic at all. With IDES, we reach this maybe already after 15 minutes, because the single cleaved IgG can probably do nothing, or at least when it's double cleaved, it is not effective. So it is sort of like doing 6 or 7 plasma exchanges within 1 or 2 hours instead of doing them within a week. But that is not the only rationale why it could be beneficial with IDES in anti-GBM disease. We have also shown in animal experiments that if we have mice treated with rabbit anti-GGG and then treat the animals with either placebo or IDES, we can cleave off the FC portion of the IgG that has already bound to the kidneys. And you can see here the typical anti-GBM pattern in the placebo-treated mice, and nothing here can be seen with an FC-specific antiserum. If you use an FAB-specific antiserum, though, you can see the heads of the antibodies still being in the glomeruli. So based on this, we, and with the help from UVAS and other, we were able to gather a large number of hospitals around Europe that would like to participate in a trial. It was an open-labeled, non-randomized, multi-center study where IDES, or imlifidase as it's called, was given on top of standard of care. And plasma exchange for all patients were given on demand, which is that the plasma exchange regimen is tailored according to the titers. We aimed to get 15 patients, and we figured with 1.5 per million and some exclusion criteria, and not getting all patients that would fulfill into the study, we would need a catchment area of about 35 million from the hospitals. And for that we recruited large hospitals in large cities. And we had 5 sites in Sweden, 2 in Denmark, 4 in Austria, 1 in Czech Republic, and 5 in France. The inclusion criteria were that there should be an indication for plasma exchange based on circulating antibodies. Patients should have an EGFR less than 15, indicating that they should have at least a bad, if not terrible, prognosis. They should have a sign of renal disease, an active urinary sediment, or at least microscopic hematuria. Only adults were included in the study. Exclusion criteria included that there should not have been anuric for more than 42 days or had dialysis more than 5 days. And also severe and moderate pulmonary hemorrhage was not included. During the study period, there were 26 patients seen at the centers, and some had too good renal function, others had other exclusion criteria, but 15 patients were included and all were treated. 10 of them were dialysis dependent at the time of treatment, 5 had an EGFR less than 15, varying between 7 and 14. Of the 10 dialysis dependent, 5 were oliguric or anuric. And here you can see the characteristics of the patients. I could point out that they were quite old. They were 60 years old. 6 of them were, that's about a third, were ANCA positive. Some had other autoantibodies. 2 had mild lung hemorrhage, and another 5 of them had other pulmonary symptoms suggestive of some sort of lung engagement. As expected, when we treated them with imlifidase, IgG levels dropped dramatically already after 2 hours and started coming back between 3 and 10, between around day 7. For anti-GBM antibodies, as you can see here on the right panel, it also dropped dramatically and was almost unmeasurable in all patients after 6 hours. But there were rebound in some of the patients, but not all. And then these rebounds were treated with plasma exchange. On the safety side, we can say that there were no infusion-related adverse events. There were no severe infections during the first 4 weeks in the trial. There were 8 SAE in total, but they were assessed as probably or possibly, or not probably or possibly related by the PI at the local site. That included 1 death of pneumonia occurring 2 months after start of therapy, and that patient had also received a very large number of plasma exchanges. So here are the results with respect to renal function. At the end of the study, 1 patient had died, but 10 patients were out of dialysis and alive, and there were 4 patients dialysis dependent. Actually, no one got worse, and so all that had an EGFR less than 15 had an EGFR above 15. Some of them very good after 6 months. Of the patients that were oliguric and not in dialysis, all 4 of them could leave dialysis, and actually the 5th one could leave dialysis just after the study, so we cannot have it on the slide, but I can tell it to you. So there were actually only 3 patients who were still in dialysis at 1 year. We compared these results with a retrospective study that we had done in collaboration, actually Vladimir, Stephen, and me, the 3 persons you can see here. And we had patients from the UK, from Sweden, and from the Czech Republic. They were collected here between 2000 and 2013. And they could, from this group of patients, we included those that had been treated with Plex and had an EGFR less than 15 at start of treatment. And 50 patients that were generated. And when we compare them with the good ideas cohort, we can see that they were quite similar with respect to age. They were almost the same proportion of ANCA positivity, little bit more dialysis in Stevens' cohort, and of course more lung hemorrhage, as that was a exclusion criteria in the good ideas trial. When it comes to histology, normal glomeruli is the most important, and there was not much of a difference. If we then look at the results, you can see the bottom line that there was 67% in the good ideas trial compared to 18% in the observational study, which is very suggestive that actually treatment with imlifidase makes a difference. But of course, it is no proof as this is not randomized. So to summarize, anti-GBM is the most aggressive form of glomerulonephritis, and it is mediated mainly by IgG antibodies. I would say that this study gives further support for this notion. Imlifidase degrades circulating in kidney-bound antibodies within a few hours. And in this phase 2 trial, it was associated with a 67% renal survival, which is better than we could have expected from historical controls. There were no major safety signals. And now the company is very happy for this, even though they were not so interested 5 years ago. They are now very interested and are planning for a phase 3 study to start later this year in the EU, UK, and the USA. And that will hopefully tell us if these results will hold or not. And I will conclude by acknowledging all the persons who have helped out with this study, and it's really a large amount of persons who have helped us to conduct this study. Thank you so much, and by this I will give the word back to Vladimir.
Dear Mårten, thank you very much for this very nice presentation with exciting new data, exciting new modes of treatment, which will hopefully be confirmed in the phase 3 trial, and the drug will be available for our patients. And before the discussion, we have the second presentation, which will be given by Steve Adoo from London. And this will be dedicated to the combination of membranous nephropathy and anti-GBM disease, and what are the consequences, and what is the clinical phenotype. So Steve, your turn is now.
Thank you very much. Rare and perhaps slightly complex topic of the link between anti-GBM disease and membranous nephropathy. So on the face of it, anti-GBM disease and certainly primary membranous nephropathy seem to be quite distinct clinical entities. They have distinct epidemiology and demographic associations. They have distinct target autoantigens, with the basement membrane and specifically the alpha-3 chain of type 4 collagen being the target antigen in anti-GBM disease, whereas podocyte antigens are the target of the autoimmune response in membranous nephropathy, most commonly PLA2R or other and evolving antigen targets being identified. The predominant antibody subclass in anti-GBM disease is IgG1 and IgG3, whereas it's IgG4 in membranous nephropathy. And of course, the clinical presentation is very different, with anti-GBM disease presenting with rapidly progressive glomerulonephritis and pulmonary renal syndromes, whereas membranous presents with nephrotic syndrome. Relapse and indeed recurrent disease after transplantation in anti-GBM disease is incredibly rare, whereas relapse in membranous nephropathy and recurrent disease are both much more common. So epidemiologically, immunologically, and clinically quite distinct disease entities. I guess the one thing they have in common is that in some populations they have a shared HLA association. So in anti-GBM disease, a strong association with inheritance of HLA DRB1 1501 alleles is recognized in populations around the world. And there is an association shown with the same allele in Asian populations with membranous nephropathy, though there are other stronger HLA associations in Caucasian and European populations. Though having said that, I'm sure we have all seen cases of membranous nephropathy with crescents or of anti-GBM disease with membranous features on the biopsy. So clearly there's a link between these conditions or these kind of patterns of pathology that I'm going to talk more about today. But to start, I thought I would present first of all, two interesting and peculiar cases that we've seen locally that demonstrate this association. So the first case is of a 72-year-old female of African descent, who was referred to us in 2019 from the rheumatology department. She had a history of extrarenal lupus dating back 9 years with features of rash, alopecia, and arthritis, with positive antibodies for ANA, anti-Ro, and anti-RNP, and she was on treatment with hydroxychloroquine. And she was referred to us with proteinuria, non-nephrotic proteinuria, and normal kidney function. Those are the parameters shown there: a creatinine of 70 and a protein creatinine ratio of 131. And the key features from her kidney biopsy are shown here on the right-hand side. So on light microscopy at low power, the majority of the glomeruli looked normal, though at high power, you could see that there was some thickening of the basement membrane with these characteristic spike appearances shown on silver stain. Electron microscopy confirmed the presence of subepithelial electron dense deposits, and in immunofluorescence, these deposits were positive for IgG and for C3, but not for IgA, IgM, or C1q. So a lupoid membranous nephropathy, but not strictly meeting diagnostic criteria for a class 5 lupus with full host immunology. I should highlight on this lower right-hand panel that there were some tubulo-reticular inclusions seen in her endothelial cells, which again give it a lupoid flavor, but not meeting diagnostic criteria, I guess, for a class 5 lupus. So she was treated initially with renin-angiotensin blockade, and we were in discussion about what immunosuppression she might receive, but unfortunately she didn't return to the clinic for a period of 8 months. She absconded during the latter half of 2019, but represented to us in March 2020 at the onset of the COVID-19 pandemic with a 2-week history of lethargy, nausea, and visible hematuria. And she had an acute kidney injury with a creatinine at 1337 at peak. She was oligoanuric and dialysis dependent at presentation with a normal chest x-ray. Her lupus serologies at this time were unchanged. She was ANCA negative, but her repeat immune screen threw up a very strongly positive anti-GBM antibody titer of 623. And she underwent a repeat kidney biopsy. And this showed a diffuse crescentic glomerulonephritis affecting all 17 of the glomeruli that we had in the biopsy sample. There was very severe glomerular inflammation, as you can see here, with these large circumferential presence and rupture of Bowman's capsule. And on silver stain at high power, you can see that there were still these membranous features present on the silver stain, with basement membrane spikes seen here on some of these capillary loops. And on immunofluorescence, there was the classic segmental linear staining for IgG, but with superimposed granular capillary wall, chunky IgG and C3 staining, but again, negative for IgA, IgM, and C1q. And electron microscopy confirmed the presence of subepithelial electron dense deposits. So in summary, this biopsy showed a diffuse crescentic glomerulonephritis with 100% involvement of glomeruli with concomitant features of her previous membranous nephropathy. So she was treated with plasma exchange. She had a 14-day course of plasma exchange that was extended for a further 5 exchanges due to a rebound in her anti-GBM antibodies. She had intravenous cyclophosphamide and rituximab and a course of oral prednisolone followed by MMF and hydroxychloroquine maintenance. And somewhat miraculously, she recovered from dialysis after 8 weeks of treatment, which is uncommon with that proportion of glomerular involvement from crescents. And you can see here her long-term changes in her creatinine, her EGFR, and her urine protein creatinine ratio out until her most recent follow-up, which was yesterday in the nephrology clinic, when she had a creatinine of 162 and an EGFR 26 mils per minute and remains anti-GBM antibody negative, but with low-level positive lupus serology. So then the second case is the case of an 8-year-old man of British descent who presented to us in July 2019 with a 1-month history of leg swelling. And he had nephrotic syndrome with renal impairment. So his presenting creatinine was 294 and he had a UPCR of over 1300 with a serum albumin of 22. So an enthusiastic immune screen was sent off, and it returned a number of positive results. He had positive testing for anti-PLA2R antibodies at a titer of 114. He had positive anti-GBM antibodies at a titer of 74. And he also had an IgG kappa paraprotein of 13 grams per liter with a clear kappa light chain excess on his serum-free light chain assays with a ratio of 8. So we really weren't sure what this gentleman's biopsy was going to show with that complex of serological testing. So his kidney biopsy showed a focal crescentic glomerulonephritis affecting about 40% of his glomeruli with a mixture of cellular and fibrocellular crescents. On silver staining, there were segmental areas, again, showing spikes within the basement membrane, thickening and spikes within the basement membrane compatible with membranous features. And on immunofluorescence, although unfortunately I don't have an image, he had, again, linear fluorescence for IgG with superadded granular staining of the capillary wall. And on electron microscopy, again, these characteristic subepithelial electron-dense deposits. There was equal staining for kappa and lambda light chains within the glomeruli, and these were polyclonal deposits. So there was no evidence of a light chain kind of glomerulopathy in his kidney biopsy, though he did have some vascular AL amyloid deposition, but nothing within the glomeruli. So a focal crescentic glomerulonephritis secondary to anti-GBM disease with features of a concomitant membranous GN. He too was treated with plasma exchange, cyclophosphamide, rituximab, and steroids, and he had a response to treatment with an improvement in his GFR and serum creatinine and proteinuria over the subsequent 6 months. And when he was last seen in March 2022 at 2.5 years follow-up, he had a creatinine of 197, a GFR of 27, subnephrotic proteinuria, and negative testing for both autoantibodies. These were his autoantibody titers followed up over time. So quite a brisk response in terms of his initial response to immunosuppressive and plasma exchange treatment. So these are two unusual presentations of anti-GBM disease associated with membranous glomerulonephritis. The first was of a lopoid membranous antecedent to anti-GBM disease, raising the possibility that the membranous acted as a trigger for the onset of anti-GBM disease. And the case was unusual in that the patient had a very favorable response to treatment given the severity of kidney injury at presentation. It must be said that anti-GBM disease in patients with the presence of anti-GBM antibodies and anti-GBM disease in patients with lupus or lupus nephritis is exceedingly rare. So this is a very peculiar case. The second case was of concomitant membranous nephropathy with anti-GBM disease with dual positivity for both anti-GBM and anti-PLA2R antibodies, both in serum and in tissue. And again, this is an uncommon association because, as we'll see, most cases of membranous anti-GBM disease associated with membranous are not positive for anti-PLA2R in the literature. So taking a step back, thinking about crescents and membranous glomerulonephritis. Crescents and membranous GN have heterogeneous associations and outcomes. So this is a recent series that we published from the Hammersmith Hospital here in London, looking back at all of our cases over a 15-year period of membranous nephropathy with crescents on the biopsy, though excluding patients with a clear lupus nephritis. And we found a mixture of disease associations with 7 patients having an associated ANCA, 5 with anti-GBM disease, 2 with positive testing for anti-PLA2R, and 1 who was seronegative for all the autoantibodies tested. All presented with nephrotic range proteinuria, all had severe renal impairment at presentation, and these patients had variable prognosis with 40% progressing to end-stage kidney disease during follow-up. So clearly there are, as I said, heterogeneous associations and outcomes of these patients who have membranous and crescents together. Thinking specifically about that subgroup of patients who have got membranous glomerulonephritis with crescents, but excluding those with a clear secondary cause for their crescents, so excluding those patients with anti-GBM disease or circulating anti-GBM antibodies, excluding those with ANCA, lupus, post-infectious GN, and PGN mid. There have been 3 series that I found that described this association with a frequency of between 0.4 to 9.5% in series, and it appears to be more common in the Asian series. These cases share the demographic features of idiopathic membranous with onset in the 6th decade and the male preponderance. And in common with idiopathic membranous, they present with nephrotic syndrome. And when tested, 38 to 80% of these patients were positive for anti-PLA2R antibodies, suggesting that the presence of crescents may be part of the spectrum of primary membranous nephropathy at a severe end of the spectrum. Histologically, they present with a focal crescentic glomerulonephritis affecting between 5 and 25% of crescents. And perhaps not unexpectedly, they are more likely to present with renal impairment than patients with idiopathic primary membranous without crescents. They're less likely to achieve remission, and they have an increased risk of chronic kidney disease and end-stage kidney disease during long-term follow-up. And these are two of the survival curves taken from these references, just to illustrate the point that those with crescents in the solid line on both graphs have a high rate of adverse kidney outcome. So it's possible that crescentic membranous nephropathy is a rare variant that responds variably to treatment and tends to a poorer outcome compared to patients with idiopathic or primary membranous nephropathy. And I would suggest that this is perhaps distinct to the membranous nephropathy associated specifically with anti-GBM disease, when you actually detect circulating or deposited anti-GBM antibodies in the same patient. So this association of membranous specifically with anti-GBM disease may occur in any sequence, with membranous coming first, with anti-GBM disease coming first, or with the two diseases being diagnosed concomitantly on the index biopsy. So the first case of membranous transforming to anti-GBM was published in 1974. This was a case of a fatal case of rapidly progressive glomerulonephritis due to anti-GBM disease that was diagnosed on post-mortem in a patient who had previously been treated for membranous nephropathy. There are a small number of cases since reported in the literature, and it tends to occur in middle-aged or older patients with an interval of months to years between the two presentations, and they tend to have poor outcome, and end-stage kidney disease is common, I guess, like patients with anti-GBM disease as the primary diagnosis. The sequence of anti-GBM disease followed by membranous is less common. It was first described in 1976 in a patient who had Goodpasture syndrome, and then 7 months later presented with nephrotic syndrome with membranous nephropathy on the biopsy. There are a handful of cases again reported of this sequence in the literature. It tends to occur in younger adults with a slight female preponderance, again with a months to years interval between the two diagnoses, and recovery is more common, I guess, because the second phenotype of membranous is more likely to respond to treatment. However, the most common pattern of these diagnoses being made together is on concurrent biopsy at the time of initial presentation. And there are two series that I'll present briefly that have described patients with this phenotype. So the first is a study from China that identified 8 patients with combined anti-GBM and membranous features on biopsy, and they compared this cohort of 8 patients to 30 patients with classic anti-GBM disease without membranous who were age and sex matched. And in the patients with membranous nephropathy, they tended to present with lower serum creatinine, higher levels of proteinuria, similar levels of anti-GBM antibodies, and a lower proportion of crescents on the kidney biopsy. None of these patients were positive for anti-PLA2R antibodies in serum, and none had IgG4 deposition on their kidney biopsy, which suggests that these patients didn't have a primary membranous nephropathy, and that this was perhaps related to the anti-GBM disease rather than having a second diagnosis of primary membranous nephropathy at the same time. In this series, the presence of membranous nephropathy was associated with a better outcome. This is the survival curve shown up to 30 months here. Though it may be that this could be due to treatment or to the disease severity of the anti-GBM disease at presentation, because as we'll see in the next series of a larger cohort of patients from Colombia, this recent study identified 12 patients with the dual diagnosis of anti-GBM disease and membranous nephropathy on kidney biopsy, with a median age of 48 and a slight male preponderance, who had a much more severe disease phenotype. All were dialysis dependent at presentation. 75% had subnephrotic proteinuria, perhaps because they had impaired glomerular flow from their bad nephritis, and only 1 had pulmonary manifestations. All who were tested had circulating anti-GBM antibodies in serum, and serum anti-PLA2R testing was not available. But of those tested, only 1 had PLA2R positive staining on biopsy, again, suggesting that this phenomenon isn't due to the co-occurrence of primary membranous nephropathy in these patients. Histologically, this cohort of patients with more severe disease than the Chinese series, with a higher proportion of crescents of glomeruli involving crescents, and all had diagnostic features of membranous nephropathy on the kidney biopsy. This cohort was treated as for anti-GBM disease, in general with plasma exchange cyclophosphamide and steroids, though despite treatment, they had poor kidney outcome, with only 2 of the 12 patients recovering kidney function from dialysis requirement at presentation. So in this series, anti-GBM disease appeared to be the dominant disease phenotype, and it looked like the traditional features such as renal function at presentation, dialysis status, and the proportion of normal glomeruli seemed to predict outcome more importantly than the presence of membranous on the biopsy. So what might be the mechanisms of this association? So central to the pathogenesis of anti-GBM disease is the conformational change within the glomerular basement membrane, such that cryptic or hidden epitopes within the collagen chains are released to immune detection. And this may account for the association of anti-GBM disease with a number of disease processes or pathologies that might disrupt the glomerular basement membrane, like ankylvasculitis, smoking, lithotripsy, pulmonary infection. So you might suggest that in patients with membranous glomerulonephritis, whatever the target of the membranous antibodies and whatever the membranous autoantigen is, there is an altered quaternary structure of the glomerular basement membrane that exposes the cryptic immunodominant epitopes within the alpha-3 chain of type 4 collagen, permitting de novo generation of anti-alpha-3/4 collagen antibodies. In addition, the disruption of the quaternary structure of the GBM may permit the binding of these de novo antibodies or of pre-existing antibodies, such that these antibodies can initiate anti-GBM disease, accounting for the association of these 2 pathologies. Going the other way, how might anti-GBM disease account for membranous nephropathy? Well, central to the pathology of membranous is the deposition of immune complexes of a circulating antibody with podocyte antigens being shared into the epithelial surface of the basement membrane. And so it's possible that in some patients with anti-GBM disease, they deposit alpha-3/4 NC1 complexes within the glomerular basement membrane, either due to altered physical or chemical properties of the basement membrane that predispose it to developing immune complexes as part of the immune response to alpha-3/4 collagen. And there's some evidence from animal models that there may be distinct reactivity or distinct immune reactions to alpha-3/4 collagen that account for the presence of membranous. I don't have time to present all of the experimental data, but it is interesting that in animal models, heterologous immunization with the alpha-3 chain of type 4 collagen in some rodent strains will induce anti-GBM disease, but in others will induce membranous nephropathy as the main pathology. And that is dependent on the genetic background of the rodent strain used. Recent work sequencing the immunodominant epitopes that alpha-3/4 within alpha-3 chain of type 4 collagen also suggests that the immunodominant epitopes that account for membranous and anti-GBM disease in the rodent models may be different. So this may point towards clinically there being a genetic susceptibility to the development of membranous nephropathy in some patients with anti-GBM disease. On a completely different tangent, it's possible, I guess, to suggest that aberrant expression of basement membrane or podocyte antigens in the inflammatory milieu of anti-GBM disease might lead to intermolecular epitope spreading, such that you develop a de novo immune response to as yet undefined podocyte antigens that then deposit as immune complexes in the basement membrane. And that may be why in some patients with anti-GBM disease, we see this membranous pattern of pathology, but we don't yet know what that target autoantigen might be. So in conclusion, I've lost my slide, there we are. Presence in membranous nephropathy have heterogeneous associations and outcomes. Crescentic membranous nephropathy is a rare variant that responds variably to treatment and tends to have poor outcome compared to idiopathic membranous nephropathy. And I think it's probably distinct from membranous nephropathy in association with anti-GBM disease, where alpha-3/4 antibodies have been identified. Anti-GBM disease with membranous GN can occur as a concurrent event, less commonly with membranous GN first anteceding GBM disease, and much less commonly with anti-GBM disease as the first pathology. Most of these cases are anti-PLA2R negative, suggesting that we're seeing a membranous pattern of injury rather than primary membranous GN in these patients. In these patients, anti-GBM disease is the dominant disease phenotype, and the traditional clinical and laboratory features seem to predict outcome, and the impact of concurrent membranous on outcome really isn't clear. And I would suggest that these patients should be treated as per standard anti-GBM disease. And it may be that conformational or physiochemical changes in the basement membrane, coupled to intra and intermolecular epitope spreading, may account for the association of these two entities, but further work is clearly needed to define the membranous antigen and the nature of the immune complexes in such cases. And so I hope I've kept time. That's the end of my talk. Thank you for listening.
Thank you very much for this nice talk with very interesting case reports. And we have now quite time enough for a discussion. We have some questions from the auditorium in the question and answers. And I hope that we have also Mårten available. Yes, okay. So I will start with a question from the auditorium, and then we can discuss some other aspects between us. So there is a question concerning plasma exchange in anti-GBM disease. And the question is if plasma exchange is to be based on the antibody titer or the oxygen saturation, or if it is to be performed in all patients. I mean, in case you have not available imlifidase, of course. So this is a question to Mårten, yeah?
Yeah, well, I think that Stephen can also give his views on this, because I think that this is an interesting thing, really, how you should prescribe plasma exchange. For me, I mean, it is to get rid of the antibodies. And some patients then need a lot of intensive plasma exchange to lower their antibody levels, others need less. I don't really see any reason to sort of give all patients just say 5, 6, or 7 treatments and then do nothing. But of course, it depends on your assay that you're using, how sensitive it is, and the turnaround time of the assay. If it takes a week to get results, then you have to, of course, treat for a week before you can modify your therapy. But if you can get results within, say, 48 hours, you can prescribe plasma exchange until you have the results, and then you sort of can modify the treatment. That is how we do. But I know in KDIGO and other places, they do suggest that you should have sort of a more fixed schedule and adjust according to clinical responses, such as you say here, O2 or the GFR or so. But to me, that is illogical when you know that you have the culprit and you can measure it. So what do you say, Stephen?
Yeah, no, I would agree with that. So we would exchange all patients with anti-GBM disease where there's evidence of lung hemorrhage, and if no lung hemorrhage, if there's evidence of kidney disease where you think there will be recoverability. As you can see in the first patient that I presented, we are aggressive with our treatment, and we continued plasma exchange for 19 exchanges. Having taken a break after the first 2 weeks and then seeing the antibody rebound, we reinitiated plasma exchange. And so I think I totally agree. It's against the kind of the directly pathogenic autoantibody that you're able to measure, and would be my main indication for continuing it in patients where you've got evidence of recoverable end organ damage.
So O2 saturation is not important. Yes, this is also the answer to the one part of the question. So oxygen saturation is not important in this.
No, I mean, clinical response is not sort of what we use to tailor the disease. And also, I mean, the Tesar studies show that it's not really a treatment for there is no really good evidence that plasma exchange in itself is helpful in pulmonary hemorrhage if you do not remove antibodies. Actually, it could be harmful. You can cause infections. So if you don't have antibodies removed, I don't see any reason to do the plasma exchange. The problem is the patients that are seronegative to start with. There you have nothing to follow, and there it could be wise maybe to have 6 or 7 exchanges and then consider the clinical response.
And another important point, do you treat the patients with 100% crescents in the biopsy?
Depending a little bit on age and histology and how fast things have developed, but not all necessarily.
I must say that we mostly treat them. So what Stephen?
As you can see, we did treat the case that I presented. I mean, I think you take a number of factors into consideration, like age and how robust the patient is and how well they will tolerate treatment, and whether there's evidence of chronicity on the kidney biopsy. So the patient in question had no background scarring in the tubular interstitium, had no glomerular scarring. It was all very fresh, very acute on the biopsy that we had, and she'd only just had a requirement for renal replacement therapy. So she had not been on dialysis for 2 weeks with an unmade diagnosis and then kind of starting treatment. So all of those factors fed into our decision to treat that patient. So we don't have an absolute kind of cutoff of 100% presence or not. There are a lot of factors that go into it.
Yeah, I have a similar approach. And the second question concerns the relation between the use of some drugs and anti-GBM disease, specifically Montelukast it mentioned. And I would also ask you if you have any experience with anti-GBM disease after alemtuzumab treatment. So who will start? Stephen?
Okay, I'm not familiar with there being an association with Montelukast. Though I'm sure anything is possible. We've got no, I've got no direct experience of anti-GBM disease after alemtuzumab therapy. We use a lot of alemtuzumab in our transplant population. It's our routine induction immunosuppression for kidney transplantation, and we don't see anti-GBM disease, though of course all of those patients are getting maintenance immunosuppression for their allograft, which may prevent the disease happening. So no, I've not personally seen a case of anti-GBM disease after alemtuzumab. I would highlight that membranous also occurs after alemtuzumab in the literature as well. So an important point that it's not just anti-GBM disease following that drug.
Yeah, Mårten?
Well, I haven't seen anything on Montelukast. I think actually I know that some people believe that in EGPA, where it has been shown that it is actually that steroids is good at treating EGPA, but Montelukast is not good for treating EGPA. So if you have a patient with asthma that is really EGPA, then when you reduce the steroid and that you can reduce the steroid because of then it will appear. So it's not really maybe not really a drug effect. It's just that the absence of a drug that is effective for EGPA. But that I don't know. But it makes sense to me. And if that is true, it should not really cause anti-GBM disease. But as I have never heard of it, I cannot say it's not there.
I have also no information about it. The third question is about what was partly shown in the presentation of Steve, and this is the use of Rituximab in anti-GBM disease. Definitely the evidence is weak. We have very limited data from that, but it is sometimes used. And of course, the situation in which you used it in London was specific because this was a combination of anti-GBM and membranous nephropathy. So do you also use it as a primary treatment in combination with cyclophosphamide in poor anti-GBM disease or not?
So I will admit we are using it more. So a lot of patients with anti-GBM disease are also positive for ANCA, and we've shown in the paper that Mårten mentioned that those patients do have a risk of relapse long term, and so they do have an ANCA phenotype. So in the double positive patients, quite a low threshold for including rituximab in our induction schedule, like we do for kind of our ANCA patients who many of you know will treat with a combination of Ritux and cyclo. In single positive anti-GBM disease, I have started using it more really as a cyclophosphamide sparing agent, because I think it does shorten the duration of the course of oral cyclophosphamide that you need to give the patient. So particularly in young patients where there may be concerns about fertility, for example, with an extended course of oral cyclo, I've used Rituximab in order to be able to spare that.
Yeah, but you do not use Rituximab as a single treatment without cyclophosphamide in anti-GBM disease.
No, not unless there was a compelling contraindication to cyclophosphamide or the patient refused to have it. I would never use Rituximab alone.
Or intolerance of cyclophosphamide because of severe infection. Yeah, and Mårten?
Well, I'm very impressed by the results from London with using combination of cyclophosphamide and rituximab in ANCA disease, severe. So I think that it is probably a very good treatment for anti-GBM disease, but we haven't used it ourselves. I have only used rituximab in patients who linger on, where we do not get rid of the antibodies, or that tends sort of to rebound in antibodies after a couple of weeks or so. You get tired of doing the plasma exchange, and then we add rituximab to hope to shorten the course, and I don't know if it helps. But all of them eventually stop producing antibodies, but they maybe would have done it anyhow. But so I think really that it is a good idea. But in the trial, we could not use it because imlifidase would cleave rituximab. So we could not at least have it in the first 2 weeks or so as a combination therapy. So that was an easy to choose.
Yeah. But if I'm not mistaken, in the British protocol for ANCA vasculitis, the combination of cyclophosphamide and rituximab was also used to decrease the cumulative dose of corticosteroids. Yes. Yeah.
Very impressive data, but
very impressive.
Not controlled yet.
Yeah, I was also very much impressed, and it is also a very interesting way how to treat the patients. So we responded to the first 3 questions, and the fourth one is concerning imlifidase. It says that it is really looks like a game-changing drug for this devastating, very acute antibody-driven disease. And the question is if there are any data of using it also in some other severe diseases, such as severe autoimmune hemolytic anemia or equivalent emergencies. And of course, in ANCA vasculitis, for instance, with severe renal involvement.
Yes, there was recently a case report from Berlin where they had used imlifidase off-label for ANCA-associated disease with apparent success, at least in the short term. I mean, we had ANCA positive, double positive patients in our trial, and we got rid of the ANCA very efficiently with imlifidase. So if plasma exchange is effective, why not give something that is faster? As we think that the rule for plasma exchange in ANCA vasculitis is to speed up the induction period. So I think it should be tried, but without, of course, trial, we can only guess. Right now, ongoing trial in Guillain-Barré syndrome, driven by the company. It is important when you consider using imlifidase that you cleave the antibodies. So if the pathogenic mechanism is blocking, then you will not have an effect. That was seen when it was tried in thrombocytopenic purpura, where the Fab fragment is actually the problem and not the FC fragment, and really was not effective at all. And similar, I guess you could maybe have, if you have anti-factor H antibodies or so, you will probably not be very helpful to keep off the FC portion. So it depends on, but I think that this should really can be tried in almost any situation where you do plasma exchange or renal absorption, but it needs to be tried in each and single indication with vigilance.
Yeah. We have here the question which was already partly mentioned, and this is the timing of imlifidase and rituximab. So of course it should be postponed. And about what time would you suggest? So if we use imlifidase, when we could give to the patient?
A week.
A week, yeah.
Yeah, it's there is hardly any circulating after 4 or 5 days. So it's probably 4 or 5 days would be enough, but I would maybe say a week. So you're sure that you actually get the depleting effects. So so I think if you do 6 cyclophosphamide and then wait a week and you give rituximab, you're in good shape. If you would like to combine them.
Why not repeat imlifidase instead of performing plasma exchange in those patients with, once again, increasing titers of anti-GBM?
Yes, that would have been great to try, but there is I mean, you do generate anti-drug antibodies and at huge amounts after maybe 2 or 3 weeks, and then it probably is sort of impossible to use, and you can get immune complexes that could be harmful. But it has not really been tried, and when you do it the first time, you can only do one thing. You cannot really do many things when you do it.
I see. And there are 2 questions which are related to the combination of membranous nephropathy and anti-GBM disease. The first one is alpha-3/4 is produced by podocytes. Therefore, is it a podocyte antigen?
I mean, yes. I mean, I guess it is a podocyte antigen in that sense. I guess in the first slide that I showed you was kind of illustrating the kind of the conceptual difference of where the antibody binding is happening in anti-GBM disease in the basement membrane, and I guess in membranous nephropathy with antibodies binding nascent protein as they are shared at the cell surface and then being deposited in the basement membrane. I wonder if that accounts for the presence of membranous features in some patients with anti-GBM disease, such that there's some alteration in nascent collagen as it's kind of shared and secreted by the podocyte, whether that then binds with circulating antibodies that then can deposit as immune complex in the basement membrane, but that's purely speculative.
Yeah, I think when reading, I mean, this question is from Ming Wei in Beijing, who published one of the cases and when reading his paper, I got also that maybe idea that maybe it is the newly produced alpha-3 from the podocytes that is more accessible for the antibodies, because many of us think that accessibility is a problem for the autoantibodies to the lungs and the kidneys, and maybe you have antibodies for a while before they start depositing, and maybe in some patients they start deposit first in the subepithelial part when newly not yet integrated alpha-3 is present. But that of course is very speculative, but it's maybe a possibility in some patients.
The second question is, first of all, appreciation that that was a great overview of the fascinating phenomenon of a combination of both glomerular diseases. And of course, the question is that most ideas about the etiology are mostly speculative. This is, of course, the case. And my question is, do you have any experience with the combination with other autoantibodies present in membranous nephropathy, such as anti-NEL, for instance, antibodies, because they are sometimes associated with segmental features, and possibly segmental features are more common in this combination of membranous nephropathy with anti-GBM disease.
No, not that we've proven. So I look back through our kind of biopsy series in the past few days, and the presence of membranous features in patients with anti-GBM disease is probably more common, I think, than we kind of recognize. About 10% of our biopsies, if you go back and look carefully at the electron microscopy, do have subepithelial deposits, but we've not looked at characterizing those more than routine testing for anti-PLA2R as part of the workup. I don't think we've done thrombospondin or other autoantigens, other membranous autoantigens yet.
We had one patient with typical anti-thrombin positive membranous nephropathy. There were only features of membranous nephropathy, and there was moderately increased anti-GBM antibodies, but no clinical or laboratory features, other features associated with the disease. It persisted for a relatively long time, but finally it disappeared after more than 1 year. So we have no explanation for that. So
and did you offer the patient any treatment?
The patient was treated for membranous nephropathy. With the combination of cytotoxic drug with corticosteroids and went to remission. But what persisted was anti-GBM positivity for some time, but with no urinary funding, no renal function, and it gradually disappeared spontaneously. Okay, so we have still 2 or 3 questions. The question to Mårten, once again from Beijing, is if IDAS or imlifidase cleave B cell receptor on B cell surface and may reduce B cell count.
Well, it does cleave the B cell receptor, but I have no data on the biological effect of that cleavage. I think that is, it doesn't kill the B cells that you cleave off the receptor, and they probably can put out a new receptor pretty quickly. And so I cannot really tell if this have any effect on the B cell biology. But would you know that any of you could speculate about it?
I don't know. I don't think so.
But it cleaves the receptor. It does. That is for sure.
No experience and no idea. And there was another question concerning the protocol for plasma exchange. What is your approach? How long you perform plasma exchange? How many exchanges? If it is dependent on the titer of antibodies, it was already mentioned. So possibly it could be on the repeated. So Steve or Mårten or both?
We normally plasma exchange until we have negative testing or near negative testing, what we've defined as, a pathological level. And then we do monitor the patient over the following 1 to 2 weeks for rebound of antibody, and would reinstate plasma exchange if the antibody did rebound, and it often does. It may rebound to a low level, but if it is rebounding and on an upward trajectory, we often reinstate plasma exchange, which is what we did on the first patient that I presented.
And one question is the observation of anti-GBM disease temporarily related to COVID vaccination. Any experience from your part?
So we reported a series of anti-GBM disease, a cluster of anti-GBM disease in 2020. We had 10 cases during the summer of 2020, during the peak of the first wave of infection, and we demonstrated COVID antibodies in about 50% of those patients. So I guess that, like has been shown with other types of respiratory infection, that may act as a trigger for anti-GBM disease. I think we've all had seen or heard cases of different forms of glomerular disease flaring or developing after COVID vaccination in the past kind of 18 months, though I think it's difficult to establish a kind of a causal relationship when the entire population has been vaccinated. So of course there are going to be coincident cases, and I think it's very difficult to show a causative association.
Yeah. And possibly the last question, it concerns the patient who is for anti-GBM disease on chronic dialysis, and the antibody persists and it can't be transplanted. So what is your approach to this kind of patient? The antibodies persisted for more than 8 months, and so it is a contraindication for transplantation, is it? Yeah.
Yes, that's the type of patients that I treat with Rituximab, and it does disappear, but of course I do not know if it's Rituximab or not.
Yeah, thank you. So I think that we almost used the allotted time. We had a nice presentation, a very interesting discussion. Thank you also to those who asked this question, to the question and answer chat. And I hope that you also enjoyed this webinar. And once again, I would like to invite you all to our Congress in Paris, because there will be also very interesting presentation in glomerular sessions on different aspects of glomerular diseases, including anti-GBM disease. So thank you very much for your attention. Thank you very much to speakers, and see you during our next webinar on another topic. Have a nice evening. Bye-bye.
Bye-bye.
Thank you.
Bye.